so AP Anesthesia 2, Test 1, machine check. So we're going to start out by verifying that we have got our auxiliary oxygen here with a regulator on and a key to be able to open that. We then want to go and make sure that we've got an ambu bag with a mask that's inflated that is going to be adequate to be able to mask someone. The third thing that we want to do is make sure that we've got some suction. I'm going to be hooked up to wall suction, make sure that we're strong enough that we have nice strong suction for that. The next thing that we want to do is we want to verify that we have power and that we have AC battery available. So we've got that turned on. We want to verify all of our alarms. So our alarms are working, make sure that they're turned up loud enough that we can hear them and that all of the appropriate ones are set. We're going to go ahead and check our spare O2. We're going to turn this on back here and verify that we've got at least 1,000 PSI, which we do, and we'll go ahead and shut that back off because we don't want that to leak out. Then we will go ahead and check to make sure that our pipeline pressure, our wall pressure is at least 50 PSI, which it is. 50 PSI. Then we want to make sure that our vaporizers the lids are locked, that they're filled. We'll go ahead and make sure that everything is as it should be there. And then we'll go ahead and perform a low pressure check. We want to make sure we have a nice bulb that will hold that suction there. We'll go ahead and bypass the common gas outlet by flipping that down and make sure that this will hold for at least 10 seconds. So that holds for 10 seconds. We'll go ahead and close this up here. Next, we'll go ahead and calibrate our machine. Go ahead and leave this open to air. We'll go into calibrate. We'll calibrate that to 21%. That's going to take a few minutes. While we are waiting, we'll say that that's completely done now. We've got to put this back on before we can do a high pressure check. We'll go ahead and do a high pressure check. We will turn this to the bag and then close APL and give it a good oxygen flush. And make sure that we can hold that to 30, that we can hold that to 30 for at least 10 seconds, which it's holding. Okay. We then will take and make sure that we have our absorbent is not purple, it's not desiccated, and if it is, to make sure that we change that out appropriately. We want to make sure that our containers are stacked appropriately. Also, we want to check the scavenger system. Over here on the side of the machine, you'll see where there is a green portion. We want to make sure our bubble is floating in between there. That tells us that the suction is strong enough to pull that excess gas out of the room. We want to verify our ventilation. We'll go ahead and hook up our circuit to artificial lung. And we'll fill this up, and then we'll turn this to vent. We'll watch to see as that bellows falls that the bag will tighten and soften, and we'll also check our flutter valves on inspiration and expiration, and they are both working. The next thing that we'll want to do is we'll want to document the completion of this check, confirm the ventilator settings, what our tidal volume, our respiratory rate, and our IE ratio, and our P limit, our pressure limit is, and that is my check. Okay, we are in the operating room here with Mrs. Tiffany Patterson. We're going to go ahead and talk about setup before I start actually with her procedure. So the setup I have here, I've got a Miller 2 and a Mac 3 blade. I've got 3 ET tubes. I anticipate using a 6.5. I've got a size above and a size below. I have 3 oral airways and a tongue depressor, as well as a nerve stimulator. I have tape for the eyes, tape for the tube, and I have got all of her medications. I also have some rescue medications in the event. I have got my ephedrine, phenylephrine over here. I also have the medications that let me go through the medications that I'm going to be using. So I will be using fentanyl, 100 micrograms. We've got 60 milligrams of lidocaine, 120 milligrams of propofol, 25 milligrams of ketamine, and and 70 milligrams of rocuronium. I will be giving 8 milligrams of Decadron, and the Sagamadex, we are, depending on what her reversal is, I want to know what her emergency, like rescue dose would be in the event that we could not intubate, could not ventilate. That would be 960. Other than that, and nothing's drawn up yet, we'll just wait to see what she ends up being. So we have got, again, Mrs. Tiffany Patterson here. I'm gonna go ahead and start to pre-oxygenate. She's coming in for L4, L5 discectomy. We'll discuss a little more about what happened in pre-op after I get done setting everything up, but we're just gonna go ahead, bring her in. Mrs. Patterson, I'm just gonna have you sit here, rest here comfortably, while I get some of your monitoring equipment set up. I've got oxygen going at 6 liters, and she is comfortably resting. I'm going to start by putting her pulse ox on. Mrs. Patterson, this is going to tell me, that pulse ox is going to tell me that you're getting enough oxygen. So we're going to keep that on your finger. Don't try to take that off. We have got a blood pressure cuff that we're going to put over here on your left arm. That blood pressure cuff is going to tell me if your blood pressure is stable throughout this case, okay? We have an 18 gauge IV here that will help with that we'll be giving our medications through. We're going to go ahead and do our EKG patches. This patient is going to be proned for this case, and so we're going to be doing the EKG patches on her back. Okay, so those are all on. Patches are on the back, leads are on the back, on the side. All right, you feeling okay? Are you feeling pretty comfortable? All right, so I'm checking monitors again. I'm making sure blood pressure's okay, that her respiration's okay, that she is feeling okay. She's not in any pain right now. She's doing okay. So at this point, I wanted to talk just a little bit about what we dealt with in pre-op. So in pre-op, when I walked in to visit with the patient, she was actively wheezing, and that kind of red flags for me. So as I asked her, I looked at my medical history, and she is an asthmatic patient. So she, again, Tiffany Patterson, she is a 26-year-old female, 60 kilograms, and with a history of GERD and asthma and allergies to succinylcholine and Zofran. So I asked her what the extent, how severe her asthma was, and she says, well, this is kind of normal for me, but I didn't take my morning dose of albuterol because I wasn't sure if I was supposed to do that before I came in. I asked her to take a couple of puffs of her albuterol, which she did. This cleared the wheezing. I feel comfortable moving forward with this case. Had it not cleared the wheezing, I probably would have canceled the case. But everything cleared, and I feel very comfortable with this. In regards to the medications that we gave in pre-op, she did have an allergy to Zofran, so I know I can't dose at the end of the case for nausea. So I'm going to go ahead and give 10 milligrams of IV Reglan. As well, she has a history of GERD. I'm going to go ahead and give 20 milligrams Pepcid IV to dose for that. She has an allergy to succinylcholine, which kind of threw some red flags up for me, and I asked her what that allergy response was, and she told me that the last time she had surgery, they said they used succinylcholine, and they said, you know, it wasn't anything severe, you just kind of woke up a little bit slow. Tell your next anesthetist not to use it. So we're going to go ahead, stay away from succinylcholine, and we're going to go ahead and use rocuronium instead. Now, I chose rocuronium because she is an asthma patient and there's no histamine release there. Also, it is the case anywhere from 30 to 90 minutes, and rocuronium will last about an hour. So we may end up having to redose a little bit with that. I've got some set aside over here that I can redrop. I'm not going to use the full intubating dose if I do need to do that. We'll just make that decision as we go on through the case. We did give 1 gram of Keflex in pre-op, and I gave her 2 milligrams of IV Versed. She is doing well now. We've got her back here in the operating room, and feeling, I think she's pretty comfortable. At this point, Mrs. Patterson, I'm going to have you extend your chin for me. Extend your chin, kind of like you're looking up towards me, and I just want you to relax. And I'm going to start to give you some medications that are going to make you a little more sleepy, a little more lightheaded, and then I'll explain things as I'm going, but pretty soon you're not even going to hear me. So we'll go ahead. We're going to start with 100 micrograms of fentanyl. So the 100 micrograms of fentanyl, here we go. You know what? You're going to feel probably a little bit sleepy and a little bit lightheaded with this. I'm going to go ahead and give lidocaine now. This lidocaine is going to numb your, you know what? She's totally actually not even listening to me. Lidocaine, 60 milligrams. go ahead and give propofol, 120 milligrams. That's 12 mils. As we give this, I'm going to ask my assistant to come and give cricoid pressure. Because this patient has got a history of GERD, we are going to do a rapid sequence intubation. So we've got cricoid pressure. I'm going to go ahead and give a little bit of ketamine as well. She's got good cricoid pressure there, protecting my patient from aspiration. She's going to continue to hold that until I tell her to stop. So now I'm going to go ahead and push my 70 milligrams of rocuronium. Rocuronium is going to take 45 seconds to a minute to work, so I'm going to take the opportunity to tape eyes on my patient. All right, and I'm feeling her breathing, and it looks like she's ready to go. So I'm going to go ahead and we're going to get ready to start. I'm going to start with my Miller. I'm going to scissor the mouth open. I'm going to go midline with this one. I'm taking a good look, and you know what? I've got a Coromat grade 4. This is going to be a difficult intubation. I'm going to ask an assistant to please grab me a glide scope. Thank you. So we're going to move forward, head in the sniffing position. I've got scissor the mouth open, protecting those teeth. This glide scope has a little more of an anterior view. There we go. It's like it's messed up. Okay. If I could please, keeping my eyes on that. I know I gotta kind of get in there too, but I'm watching. That cuff is sliding right through. Can you please take stylet? Oh, thank you. She's keeping cricoid pressure there. Thank you. All right, she's going to maintain that cricoid pressure. My assistant's going to go ahead and take that. I'm at 21 centimeters here. I'm going to go ahead and I'm going to inflate my cuff. Good. Inflate my cuff. And then at this point, I'm going to listen for breath sounds. We're going to hook the circuit up. I'm going to watch for chest rise, which I have, and I'm also listening for bilateral breath sounds, which I have. Good. You can go ahead and let go. I'm going to flip this over to vent mode. I'm going to watch for her end-tidal CO2 waveform, which it looks really good. At this point, I'm going to take the opportunity to secure that tube. Watching vital signs the entire time, always making sure that this patient we've got adequate pressures, that nothing's out of parameter, and we want to make sure that we keep her safe. All right. So at this point, as I've checked for breath sounds, I've got my chest rise. We intubated safely with cricoid pressure. At this point, we're going to want to turn the gases on. I've got my vent on. I'm going to turn her to 4% on sevoflurane. I'm going to turn my oxygen down to 2, and we're going to overpressure just a little bit with the sevoflurane. And as we get ready for this procedure is it requires that she's in a prone position. Before we do anything, let's go ahead and talk about the vent settings. I've got her tidal volume set at 400. I've got her respirations at 12. Her IE ratio is 1 to 2, and her pressure max is 40 millimeters or centimeters of water. So when it comes to proning this patient, there's some anesthesia implications that I wanted to talk about in regards to keeping our patient safe. So before we prone this patient, we want to make sure we have some things in place. We want to make sure we've got a prone pillow for her face. We want to make sure we've got padding to put under her shoulders and along the side of her chest, and also a bolster for her legs to keep her feet up so she's not got toes laying flat on the table. And the table that we will be needing will need to be a table where she can let her abdomen hang freely. This is called for in the procedures book, where we need to decompress the epidural veins. We'll also need to leave room at the head of the bed for a microscope that the doctor uses during this procedure. So in order for me to turn this patient prone, I'm going to need to disconnect all of her monitors. I'm going to need to turn gases off to protect everybody else in the room because I'm going to be disconnecting the circuit. And it is going to be my job to make sure the neck and the head is protected. I'm going to have several people who help me turn in conjunction to flip her onto her belly, making sure that the padding is appropriate on her shoulders, down her chest. We want to make sure that we're carefully anatomically bringing those arms up. We want to keep the angle less than 90 degrees here, and we want to make sure that the ulnar nerve is protected, that when we have the arm boards, that the arm boards are padded, but we're letting the ulnar nerve kind of hang, the elbow hang off just a little bit to make sure there's no pressure on the ulnar nerve. We're going to bolster again under her legs to keep her toes from touching on the table. And at this point, I feel like the patient is doing well. I feel like she is in a position where we want to make sure that we're checking breath sounds to make sure that we have not, honestly, I would have checked breath sounds first before I did all of that other stuff. Once I flipped her, I would go ahead and do breath sounds on her back to make sure that we had not extubated or main stemmed before I did anything else with her. Again, I would make sure that the face was protected, eye guards to make sure there was not pressure. I would make sure there was not too much flexion or extension in her neck. I would make sure that the arms were adequately positioned. I would make sure that there was a bolster under her shins to make sure that toes were not touching. So we're gonna go ahead, I'm gonna go ahead and give her dose of Decadron. We're gonna give 8 milligrams of Decadron. And I wanted to tell you a little bit about the case. So this is a minimally invasive procedure. We got a blood loss of 25 to 100 mils. We have, it's about 30 to 90 minutes long. And basically, I mean, we have her prone and we are just waiting for the doctor. In fact, I'm looking at my end-tidal SIVO and I'm at about 3% switches MAC bar. My surgeon just walked in, he scrubbed up and ready to go. So I am not going to titrate this gas at all. I want her to be I want her at MAC bar before he starts cutting. So we are gonna say now that the procedure was done. So we had hooked her, after we had turned her prone, we hooked everything back up, obviously. Now surgery is done. We put her supine doing the same exact thing. We would unhook all monitors, we'd unhook the circuit, being very careful to watch and protect her neck, and now especially her back where this surgeon has done the discectomy. So again, she's already in the supine position. We're just kind of back to a point now where we're getting ready to do what we would do in a wake extubation because she was a rapid sequence intubation. So I'm gonna go ahead and turn my gases off. I'm gonna turn my gas flows up to 10 and I'm gonna let that just kind of for a minute, just kind of blow that off. Then I'm gonna go ahead and use my nerve stimulator to check a train of 4. The train of 4, when I do my train of 4, I'm getting 2 out of 4 twitches. 2 out of 4 twitches is going to call for 2 milligrams per kilogram of Sigamadex. This is going to come out to 120 milligrams of Sigamadex that I'm going to be giving. I will draw my Sigamadex up. Should be just 1.2. And this works pretty quickly. And all right, we are going to watch when the patient is waking up. Some of the things we can watch for is blood pressure. Blood pressure is going to go up. She's going to become a little more. She'll start to wiggle a little bit. We may see her starting to blink or even groan. I can see that she's starting to wake up. And so, Mrs. Patterson, hey, wake up! Can you wake up for me and open those eyes? There you are. Your procedure's all done. I know we talked about you having a tube in your mouth when you woke up, and I know it's awful. I can see you're fighting that. I know it stinks. We're gonna get it out, but first I have got to do some suctioning. I need to make sure that you don't have any secretions down there. Make sure that everything is safe for us to take that tube out. Now, one of the things I want to be watching before I even think about taking this tube out is I want to flip my patient over to bag mode and just so see if she's spontaneously breathing. I want to see how much tidal volume she's pulling, so I'm suctioning good here. Good. And then I'm just going to kind of watch. gonna watch and see, and I'm watching as she's pulling her tidal volume. She's pulling 400 right now. I can see she's got good chest rise. Her end tidal CO2, she is at 40 right now and not rising. Her respirations are she's about 14 right now, doing well. Blood pressures are stable. Can you open your eyes again for me? Good, good. Wiggle your fingers for me. Can you wiggle your toes? Good, good. She's following command. I feel like that we are okay to extubate this patient. Mrs. Patterson, I'm gonna go ahead and start to untape this tube. I know, we're hurrying. We're almost there. We'll get it out. All right, so I'm gonna go ahead and I am going to deflate my cuff. What's important that we wanna make sure that we're doing, we'll deflate this cuff. We wanna make sure that we have got, as soon as we pull this, we wanna make sure we've got that face mask on and we're delivering some oxygen, good 6 to 10 liters. We'll say we're gonna go with 6 on her. So on the count of 3, we're gonna do a nice, we're gonna pull that tube. On the count of 1, 2, and 3. Pulled, good. Face mask on. Okay, we're gonna go ahead and toss that, making sure the patient has got her face mask on. I got that backwards. There we go. Okay, and we've got her again at 6 liters. She's breathing spontaneously. She's pulling good volume still. All the while I've been watching to make sure that she's had good blood pressures, and everything has gone really, really well. At this point, I can see that she's opening her eyes and looking at me. I feel like that we have had a successful extubation, awake extubation. I feel like we're ready to take the patient back to the PACU and visit with the family about how the procedure went.